I'm very excited that this is the 20th Ryan White Clinical Conference. We are very fortunate to be able to host it again this year. It's a huge amount of work from many people to bring this to you. The clinical conference is funded by the Health Resources and Services Administration in a grant to Rutgers University through the National AETC National Clinical Consultation, NCRC, National Clinical Resource Center, and with a subaward to the International Antiviral Society USA, who organizes the conference and sponsors the CME. And with that, I'm going to turn it over to Mike Sag. Mike?
Thank you very much, Laura, and welcome everybody. It's great to chair this meeting again with you, and this time with Dr. Ian Dorio from New Mexico. We're happy to be with you. I wish, obviously, it could be in person. Next slide. So this is, Laura said, the 20th Ryan White Conference. A lot of you have been here with almost all of them, but the feedback we've gotten year after year has been phenomenal in terms of having this meeting meet the needs of providers on the front line. I will add that the meeting is really designed for folks who are in the trenches seeing patients every day and making clinical decisions. So this is for primarily targeting those who prescribe, basically. So it's the physicians, the nurse practitioners, the DOs. It's also geared towards pharmacists on the front line. And this year, for really the first time, because we're virtual, we could expand to include RNs who are also in the trenches here. Importantly, those who are new to HIV care are very welcome. And even though it's going to be pitched at a pretty high level, there's going to be enough background, I think, so that you can be brought up to speed quickly. The CME sponsor for this is the International Antiviral Society USA, which is a 501c3 organization based in San Francisco, whose mission is to provide relevant, high-level educational content to providers on the front line of taking care of patients with HIV, but also other viral diseases. Next slide. There are 14 CME credits that are approved for this through the IAS-USA. You can see listed here that you can also get MOC points from the ABIM if you're eligible for that. The American Academy of Family Physicians does not allow the introductory slides to be counted or introductory comments, so it's 12.75, but everybody else is at 14 credit hours, and pharmacy 1.4 CEUs. Next slide. So information about financial relationships for all faculty is available on the platform. We're going to talk about the platform in just a minute, but on the platform, it's got faculty disclosures and a lot of information that you can access prior to each plenary lecture and the workshops. So there's going to be, because this is such a large group, normally you're used to working out of Zoom, but in this case, we decided to push the actual content of the meeting out through a different mechanism. And so that means there's about a 20-second delay, maybe 25-second delay between what I'm actually saying and when you're actually hearing it. And that's fine for the regular presentations. However, when we have polling questions, you might see the polling questions come up a little bit early so that we can make sure it gets to you. Now, if you have your screen up to full maximum presentation, in order to see the polling questions, you'll have to minimize that a little bit so that the polling questions will be pushed to you. And we'll try that out here in just a second. But it's one of the issues that we have to accommodate because of the system that we're using to push out this to such a large number of people. As far as questions and answers, you'll see that there's a button for you that says ask, and then it's like a regular question card. You can put your name in if you'd like, you don't have to, but the key thing is obviously to type the question in and send it in. I'm kind of in favor of that because I always have trouble reading handwriting sometimes. So it's okay if you have typos. It'll probably still be a lot easier. And also, you'll notice that I'm wearing headphones. That's because my microphone works better, and also I'll be doing air traffic control for Chicago as the meeting goes on. Next slide. So here's the platform. You notice off to the left-hand side of your screen, there's all kinds of things that you can use. Encourage you over time to mess with that and see what's there. But there's a schedule, there's evaluations, which will really important for us to get from you every year. We use that to update what we're doing the following year. The chat feature allows you to sort of talk to other attendees individually or in groups. The materials I've already referenced, but that's the pre and post conference materials, and including the information about speakers and the evaluations. What's important to know here, you can start evaluations even after the talk is given and then come back the next time. But the key is you have to be using the same device and browser. Otherwise, you won't be able to reconnect. But most of you are probably doing that. Next slide. All right, so we had a pre-activity knowledge practice assessment, and we didn't do so well as a group. 6% passed, but 94% didn't. That's actually a great opportunity. We deliberately made the questions challenging, and they're related to content that you're going to be hearing about. So we'll do the questions again afterwards, and I'm sure we'll get pretty close to 100% on the redo. Next. All right, so let's try out this polling thing. So what time is it for you now? And I realize it's more like 15 minutes after the hour, so you can make that 7:15, 8:15, 9:15, etc. Let's go ahead and see how the voting works. Okay, we got voting underway. And we can see that for the majority of you, it's looking like East Coast might be winning, but we'll give it a few more seconds here. Okay, let's post this up. Let's push the results out to the group if we can. Okay, and I'm still seeing the poll on my screen, but I'll just keep rolling ahead. It looks like the majority of people said it's East Coast time. I don't know if it's possible to clear my screen of the poll because it's still, that's all I'm seeing right now. But okay, great. Let's go to the next slide. So what's your degree or license? I think it's self-explanatory. Go ahead and vote. Okay, let's close the poll and see where we are. Looks like the majority are MDs or DOs. Fair number of MPs and RPAs and RNs and pharmacists. Great, just exactly what we thought we would be seeing. And I think we have one more question here. How many prior Ryan White conferences have you attended? Go ahead and vote. So it looks like the polling is working. I think now that we're comfortable with that, I will try to play a little music.
I dreamed that I would climb over the moon in ecstasy, but nevertheless it's there that I'm shortly about to be.
All right, so we got a golden ticket to attend the Ryan White conference. And this is the first for the majority of people. But we have some who have been to all 20. That's fantastic. Let's go ahead and move back to the slides if we could. Great. All right. So again, I'd like to welcome everybody. I think this is going to be a great conference. I'll go ahead and we'll move on to our first speaker, who is Dr. Cheever. Everyone knows Dr. Cheever from her fantastic work at the HIV/AIDS Bureau, otherwise known as HAB, where she leads the Ryan White program, as well as several other things that have to do with helping people with HIV. She's a passionate advocate for patients, but also providers, and representing us within the HHS to make sure that not only are the patient needs being met, but our needs are being met too. And she's going to give us an update on what's new at HAB and what's happening within HHS. So Laura.
Great. Thanks so much, Mike. First, I want to start by acknowledging that this is the 30th anniversary of the Ryan White CARE Act being passed in August 18th of 1990. It's interesting that overall this time, our vision of optimal HIV care and treatment for all, and mission of providing both leadership and resources to people in order to increase access to and retention and care and treatment really has not changed. So I want to thank everyone for the important work you do to make this happen. And I wanted to start by just reviewing a little bit of our data. All of you in your program submit client level data to us, which is quite a bit of work. We understand that, but it's very, very important for us to be able to demonstrate to stakeholders the impact of the program. And you can see if we look from 2010 to 2018, that viral suppression has actually increased dramatically in the Ryan White program. These are people that have come into care at least once in the year. It's increased from about 69.5% to 87.1%. And in that increase, some of it obviously is because medications have gotten easier to take, but also we've had a tremendous focus on reducing disparities within the program. And those efforts have actually borne great fruit. So here you can see the map of the country in the viral suppression by state. The darker red is worse, and you can see that we have significant variations in viral suppression. If you compare 2010 to 2018, all states have improved, but we continue to have significant disparities among states, particularly states in the Southeast. This slide is a little busy, but I think a very important slide. Here we're looking at changes in health disparities among some key populations. The bottom darker green dotted line at 69.5% is the overall viral suppression rate in 2010. And then the darker green bars are various subgroups across, I'll just read them, Hispanics, MSM, people who inject drugs, African Americans, transgender youth, and unstably housed. And you can see that we had some significant disparities in 2010, particularly among African Americans, transgendered people, youth, and the unstably housed. The top dotted line, the Kelly green line, is among viral suppression rate nationally in 2018. And then the corresponding bars are the rates in those populations. And you can see that we've actually reduced the disparity gaps in every single group except for the unstably housed. Unstably housed people need to be housed. And that, I think, is the bottom line that we can learn from this. But by really focusing on populations and providing more specific services and more culturally sensitive services to patients, we can improve disparity gaps among multiple groups. And I think that is an important lesson right now, particularly among the greater conversation we're having with COVID and among issues around social and racial inequity around the country. So the biggest thing we've been working on in the Ryan White program in the last year and a half or so has been the Ending the HIV Epidemic initiative, which was announced by the president about a year and a half ago. The initiative really has 4 pillars. The overall goal is to reduce, in 10 years, to reduce the number of new infections in the country by 90%. That would reduce our infection rate to a little less than 3,000 infections per year, which meets the WHO definition of ending the epidemic. Our goal is ambitious in the first 5 years, is to reduce our new infections by 75%. And we are doing this through 4 specific pillars. The first pillar is to improve diagnosis. Currently, about 15% of people with HIV in this country are not diagnosed. We need to get diagnosis more broadly happening across this country, especially in key populations that are most impacted. The second pillar is treatment, and I'll discuss that in more detail in a future slide. For people that are in our program, we do a pretty good job at 87.1%, but we need to do better across the board. The third pillar is prevention. New HIV, we know that we have pre-exposure prophylaxis. We've had that technology and understanding of how to do of how it works for many years, but we haven't implemented yet. So this is a chance to really implement pre-exposure prophylaxis as really, and also to expand syringe service programs. I can't tell you how excited I am to be in the federal government talking about expanding syringe services. Very exciting time for us. And the fourth is to respond. And this really has to do with better detecting clusters, doing better outreach, molecular epidemiology to respond to outbreaks. I think we've all been talking a lot about the importance of case finding around COVID, and that is also true among HIV. So in the first 5 years of this program, we are focusing on 48 counties, Washington, D.C. and San Juan, Puerto Rico. So those 50 jurisdictions that accounted for over half of all diagnoses in 2016 and 2017. But because in the first 5 years, we really want to learn how to do this at a national rate, we also understood that we were not going to be able to learn much in those specific counties about rural HIV. So we also have included 7 states with substantial rural burdens that are outlined here on the map. And we map these to the Ryan White program. We see that 49 of the 50 cities/counties are actually in existing Part A jurisdictions, so cities that are heavily impacted by HIV. The one that was not was Hamilton County and Cincinnati in Ohio. And then the 7 states obviously are states that we would fund through the Ryan White program Part B. So the challenges for us in terms of care and treatment really are threefold. The first is that we need to do a better job of reaching those people in care, people that have come in at least once who aren't virally suppressed. How do we reach them? We need to be doing things differently. And part of this is having an infusion of resources in our program to do some of those novel things that we think will work or have worked in other places and to really expand them. Second is among the newly diagnosed. We need to make sure we're enhancing linkage to care and engagement. We know the first year of diagnosis is a time where many people do fall out of care. We know that things like Rapid Start seem to work, so how do we scale those up? And third, and I think the most complicated thing, are those people who are living with HIV, know they have HIV, and are not in care services. We need to really be changing our partners, how we do our work, and where we do our work in order to meet those people. We estimate there are about 250,000 people with HIV in this country who are not in care. Many of you take care of them. They come in and out of care. Sometimes it's breaks in care because of issues around housing. Sometimes they've been in and out of jail or prison. Sometimes it has to do with mental health or substance use issues. How do we reach those people? We have some great things that we know have worked, that we've seen work. In Detroit, they have a program where they go into people's homes who are out of care. And when they go into that person's home to try to reconnect them, they often find other people out of care in the home as well. So there are lots of different ideas people have, things that are evidence-informed that do work. And the goal of this program around ending the HIV epidemic is really to spread it, particularly to that third group that's listed there. So what did we do in the Ryan White program? Well, in 2020, we received $70 million from Congress, and so we funded the Part A's and B's that are in those 50 plus 7 jurisdictions that I had listed previously. We funded them in March, right in time for COVID. So that was not perfect, but we at least got the money out there. We've also funded a technical assistance provider and a systems coordination provider to really help spread things that work among the different jurisdictions. We've also funded the AIDS education and training centers because we know that workforce is an Achilles heel of us really expanding HIV care and treatment. If we brought the 150 that are newly diagnosed and the 250,000 that aren't in care into care, that's 400,000 people. So we really are going to need to expand how we provide care services. So I fully acknowledge that the jurisdictions and the providers, all of us, have been consumed by responding to COVID. Completely appropriate thing to do in setting an emergency. So we haven't been able to do necessarily new and different things specifically around EHE, but there have been a few things that we have done this year that I wanted to highlight, and these really all stem from things that we heard when we did good community engagement, I think, prior to the pandemic, visited many jurisdictions and talked to people firsthand about what they needed, including last year at the clinical conference. We had a chance to meet with many of you. So we have technical assistance around reducing stigma at the organizational, systems, and individual client level. We funded a project to do that. We have put out a competition if people wanted to get money to really implement Rapid Start. We know many of you wanted to do it, but had some constraints within your current Ryan White program. So we put out specific funding to do that with a little bit more flexibility. And we heard that Black women often feel left out of the current discussion, that they have special needs that weren't being addressed. So we funded a series of grants to help people put together packages of interventions focused on Black women. So those are 3 things that we were able to do this year, even in the setting of the pandemic. The other part of HRSA that's really involved in ending the HIV epidemic is the Community Health Center program. This past year, they funded 195 health centers with $54 million specifically to expand PrEP. That is their major effort. They started by funding largely programs that were co-funded with the Ryan White program because they knew they'd have champions there to help them focus on the sexual health of people who are at high risk of HIV. But they're also doing other things. They're expanding their focus on testing people, both that are within their program and outside of their program. They are increasing patient education and improving the clinical competence and humility of their providers to take care of the populations most impacted by HIV. I know all of you have been very involved, or most of you have been very involved in COVID, and at some level we've all started providing care differently because of COVID. In HRSA, we've also had a large role to play. You can see on this slide, I just listed some of the COVID funding here. The Health Center program received almost $2 billion over a very short period of time, and then pushed it out the door very, very quickly to help health centers provide their services differently in the setting of COVID, both COVID-related services and things like telehealth to help manage health center patients while during this pandemic. They've also, for the first time, directly funded health center lookalikes. So that was a big lift for them to do something completely different, and they were able to do it very expeditiously. In the Ryan White program, we received $90 million that we also pushed out within a couple of weeks of receiving it to all of you to help you provide services to people during this pandemic. The Federal Office of Rural Health Policies received specific funding. The Poison Control Centers received funding because we saw an uptick in calls to the Poison Control Center early in the epidemic when there was some confusion about the best ways to manage through the pandemic. And we've had an extensive involvement in telehealth in this pandemic. And we've had some telehealth resources through the Bureau of Health Workforce, Maternal Child Health Bureau, and the Federal Office of Rural Health Policy to really assist with making sure we're providing the best telehealth services possible. The other piece that's been huge, almost $200 billion of the B, has been the Provider Relief Fund. This was funding that Congress appropriated to HHS that was then assigned to HRSA to administer to provide funding to hospitals and clinicians to help them manage due to the extensive changes during COVID, including financial losses they were incurring. So HRSA has taken that on and been managing that. So people in HAB have been re-signed in detail to that work, and that's obviously impacted all of us as HRSA met that need, including the funding for people that are uninsured in terms of getting both COVID testing and COVID care. Heather Hauk, the deputy at HAB, has been in charge of that program. So our funding, by statute, we were told to fund the Part A, B, C, D, and AETC, so we did that. We made our funding as broad as we could. You could spend it on PPE, minor renovations, COVID testing, telehealth infrastructure, phone minutes for patients, housing, transportation, emergency food, as people with HIV had increased financial hardships because of the epidemic, staff training. We also work to have flexibilities to meet the needs of people with HIV related to this pandemic. I've got to tell you, we actually have the best lawyers, I think, and HAB in the entire department, and they were able to help us find ways to provide significant flexibilities in terms of how the funds were used, including waiving the 75% core medical services requirement, the EIS requirement in Part C. So that was a huge benefit to us, and I want to thank them for their work on that. We have really stepped up in a number of ways. We've increased our communications to recipients. We started having monthly webinars called Have You Heard? We've had a web page set up to centralize information. We've been able to extend deadlines around grant applications. I was really excited. We were able to work with our grants office to delay the Part C recompetition by 1 year. It was just very clear that it wasn't going to be able to happen this year. I want to thank all of you that give us feedback about things that you think we need to do differently, because we take that very seriously and act on that. We've also been trying to provide guidance as quickly as we can. All the guidance is getting cleared through the department, but we have daily frequently asked questions that are being released. We've been able to delay site visits, and we've been able to work with our federal counterparts, including closely with the department, but also with HHS around getting treatment guidelines, guidance around COVID specifically. So as I said, we do know that people have not been able to do a lot of new and different things related to EHE directly, because they were responding to COVID since February and March. However, we do have some things that have happened as a result of COVID that we think translate to really accelerate our EHE response. The first thing is the adoption of telemedicine. We all felt telemedicine was an important part of EHE, an important part of expanding care to people. And now really at this rate, still anecdotally, we've seen that we've had significantly improved retention rates. And I've gotten emails from people around the country saying how they've been able to connect with patients that had always been hard to connect with, because now they could talk to them on the phone. Telemedicine's always been allowable in Ryan White, but there are a lot of constraints in telemedicine that have been lifted more broadly in other programs, particularly Medicare, that have allowed us to use it differently. I am concerned about the digital divide. I think we don't really know what the benefit is of having a phone call, which is what I do for most of my patients, because they can't negotiate the complexities of trying to have a video visit with a video visit. But I think as we continue to expand telehealth, and hopefully it will continue to expand after the epidemic, we can really understand better about what is the best ways to provide telehealth, giving patients their choices. We know, for example, that a lot of patients being in the clinic is one of the few times where they can actually be themselves and be out about who they are. And a lot of them are losing that in that kind of telehealth visit. We've also had extensions of medication refills. We know that missing doses for some patients is all about that 30-day refill. So 90-day refills have now become the norm, as has increased home delivery. Everyone is home, so they're more willing to allow their medications to be delivered to their home. Self-testing, I think, is going to be a huge thing for PrEP, where people have tests mailed to their house. They do their test and they either email their results back in or communicate the results back. And we know in Ryan White that eligibility and recertification is a big bugaboo in some areas. Other areas, it's not much of a problem at all. But recipients have really had to reassess their processes for eligibility and recertification and streamline them. And we're hoping that those will continue beyond the pandemic. So other work that we've been doing within HRSA in the last few months, or in the last year or so, I wanted to highlight. We often have what we call technical expert panels, which is where we bring a group of experts together to help us hear about what they think about key areas that we're working on. So the technical expert panels, that we've had so far in the recent year have been issues around addressing the housing needs of Ryan White clients, addressing people who are what they call justice involved, people in and out of corrections. We've looked at our Part D program and figuring out what we can do differently to really have a bigger national impact beyond just the jurisdictions where they have funding. We've looked at eligibility and recertification, and we are really looking to try to make some changes and streamline that in the coming months. Aging with HIV continues to be a high priority for us. We've done quite a few things based on the feedback we've gotten from our CDC HRSA Advisory Committee, as well as from this technical expert panel. And we are going to have enhancing HIV prevention and care among women. So those latter two are coming this fall, and we're looking forward to them. Oops, sorry about that. Other key activities, I think I've mentioned this before, and I'll just mention it again now. We know that there are things that we have not done a randomized control trial for. So we don't have evidence at that rate. And often in terms of directly providing services, there aren't randomized controlled trials done. But there are things that are done in some jurisdictions that clearly work, and they can demonstrate changes in their outcomes after they've implemented specific interventions. And we call those evidence-informed interventions. So we are working hard to collect evidence-informed interventions that work in some jurisdictions or some clinics, and really refine them, figure out what those key components are, and then spread them to others, studying whether or not we have those same impacts. So we've had a project called E2I for the last several years that the Fenway Institute has run that has been really successful. We are compiling these promising practices, and I encourage all of you who feel you have promising practices and data to demonstrate it. To help us, we will work with you to pull all together the material that we need in order to be able to share that on the web. And we are doing capacity building to support innovative models, like what things do Part A's and B's or specific clinics need in order to pick up and use this intervention. Sometimes it's about what is the contracting language look like in order for us to make this happen. We're also focusing significantly on STIs. Most of you, I'm sure, are aware of the increasing STI rates in this country, particularly around people with HIV. We are expanding extragenital testing. Rutgers has a large grant that's helping us figure out what is the best ways to increase extragenital testing in clinics and make it easier for everyone to make that happen, including self-testing, self-collection by patients, as well as focusing on making sure that we have good data connections at the state and jurisdictional level between their STI data and their HIV data. Some jurisdictions have it, some do not. We continue to focus on eliminating hepatitis C infection. Once again, in the jurisdictions we funded to do this, the first thing they needed to do was to get a handle on their data, on who had hepatitis C and HIV and was not yet treated or cured. So we are funding expansions of those efforts, as well as better utilizing data for decision making. We are working on data visualization and developing data dashboards, and you'll be hearing more about that if you attend the National Ryan White Conference. So before I end, I do want to thank all of you for all you've been doing throughout this pandemic. It's just been really heroic efforts, both on the care and treatment of patients with COVID that many of you are involved with, as well as just all you've had to do to maintain your systems of care and make sure people are accessing the care and treatment they need. I think around this country, many people in primary care felt they had no place to turn, and I did not hear that very often in Ryan White programs, that you all were really there to take care of your patients. So I want to thank you for that. With that, I will end with my email. Please feel free to email me with suggestions or comments, or pick up the phone and we can find a time to talk. And with that, I'm going to turn it back over to Mike.
Well, thank you so much, Laura. It was a fantastic overview and update. And I think it sounds like nobody is immune from the COVID vortex that we all been drawn into. And to me, I didn't know that how many of you were pulled into the COVID activity. How's everybody coping with that? How are you guys doing?
Well, for us, we were very lucky because we had been teleworking before a little bit. Most people in our program had teleworked 1 or 2 days a week or 3 days a week. And so that the conversion to telework was seamless. We were able to get all of our work done. And then as we were given more and more work to do, which all of us were, we were able to really do that in the setting of working at home. People in the Ryan White program and in HRSA in general are very mission focused. People are here because they love the community health center program or the Ryan White program, and that's why they work for us. And so they were able to, if they had kids at home, they had to take care of it 2 or 3 in the afternoon to help with their schooling. They were on at 10 and 11 o'clock at night getting their work done. So we went, I think, got everything done and much, much more, as I demonstrated there, over this time, really because of the dedication of our staff.
Yeah, it's amazing how much everybody's working overtime. Got a couple questions here. Glad to see the ask function is working on the platform. So here's the first one. With the complexity of the digital divide and video telemedicine, how can HRSA support to push for policy change with payers that deny telemedicine solely using the phone? Like it sounds like you're doing a lot for your patients, Laura. How can we address that?
Yeah, so that's interesting. So there's the Office of Advancement of Telehealth, OAT, which is a HHS office that exists by statute that actually is in HRSA. It's in our Federal Office of Rural Health Policy. So we have sort of the nidus of telehealth policy actually exists at HRSA. That said, it's been a big challenge for it's been a big challenge for us. CMS, who, you know, it does a lot of Medicaid and Medicare policy, have sort of a different set of things that they need to look at as they make their policy, but we have been pushing for years and years. And I think Joan Moran, who runs the HIV program for the state of New York, said the impossible became possible overnight. And I think telemedicine is one of those things. So we've seen it now. I would encourage all of you to be talking to people in your communities that can help leverage those changes, because we clearly understand it. The other piece is that we offer it. You can have telemedicine through Ryan White. We've never denied that. So I think it's something that we're all going to need to look at, that if a service is not available, if you have a Medicaid patient, that service isn't available through Medicaid, you can provide it through Ryan White. I mean, that's allowable even with payer of last resort. So we need to sort of see how that plays out with some of these telemedicine things, if some of these important advances are rolled back.
Great. We have about 4 minutes left and 4 questions. Let's
Okay.
see if we can get them done. Can you provide more information about at-home HIV/STI testing for PrEP?
Yeah, so there are a number of health centers, and I think we're going to hear from one. This is a pitch for Wednesday afternoon. We're going to hear from a health center that is doing self-testing as part of their PrEP program at Howard Brown in Chicago. So we can hear more about that from them. So I don't know exactly how they verify the negative HIV result, other than through sort of patient education and discussion. Certainly someone would do a lot of self-harm by continuing their Truvada if they had HIV. But we'll hear more about that from her.
Great. So at a couple of places, they're having trouble implementing the video visits, specifically because they're told that they're not HIPAA compliant for HIV patients. Are there certain standards or restrictions that they should be aware of?
Yeah, so HIPAA is not different for HIV patients than for any other patient. But I think there some of the HIPAA standards were waived as part of this pandemic. But once again, you'll need to work with the kind of your legal offices about what they're willing to do and not to do. Where I practice, they were not willing to sort of go to a lower HIPAA standard. And so our system is clunky enough that most of my patients can't get onto video visits. So that's really, I think, those decisions are being made at the individual clinic level.
Right. So you mentioned about Hamilton County and Cincinnati not being a type Part A or Part B, but was there plans for Part A funding to come to Hamilton County, do you know?
Yeah, I'm sorry. So we funded the Part B to specifically focus on Hamilton County.
Okay.
I should have made that a little clearer, yeah.
Great. For Ryan White Part A, 75-25 waiver, starting when and for how long? We're about to do allocations for the next fiscal year.
Yeah, so that waiver was specifically for the funding that we gave out for COVID-related relief. However, there is a process where you can apply for a waiver of 75-25 if you need it and meet our statute lays out what you need to do to meet that, to get your 75-25 waiver approved. So if you meet that, you can get it approved. But the flexibility we had was specifically around the COVID funding we sent out.
Yeah, and if you don't know what a 75-25 waiver is, don't worry about it. Forget about it. You would know if it applied to you. And the final question, what is the program doing to assist non-Ryan White primary care providers to improve the care of HIV patients in their community?
Yeah, so that's a great question. So the funding we have in HRSA for HIV specific funding we have is largely Ryan White funding. So that funding needs to be directed towards people that are meeting the qualifications of being a Ryan White provider. It's really exciting that the health centers are sort of jumping all into HIV now. I mean, they've been asked to by the department, and they are. And so they take care of a lot of patients that are living at or below the federal poverty line and that are minority populations. So they see other people outside of Ryan White. Frankly, sometimes there have been challenges there around some of the cultural competence and cultural humility about taking care of some of our patients that are in the traditional populations impacted by HIV, but they are really working on that now. So I think that's the one way we're doing it. The other thing is we do fund health departments around ending the HIV epidemic, and that's beyond just Ryan White. So I think with their EHE funding, which I said is $70 million in a $2.3 billion program. So it's not a lot of money right now. But if that grows over time, which is what the president had asked for in the future budget, then they'll have more funding to really specifically be able to work on that.
Great. Thank you so much, Dr. Cheever. Well done. You kicked off the meeting just like we hoped it would happen. So let's move to our first data presentation from Dr. Trip Gulick.